Yes, we can see it. Yeah.
Okay. Okay. So again, thank you. I'm very happy. I will try to help you to use how to use SView2 and PC2Gap properly, either isolated or in combination. This slide represents my conflicts of interest. My present conflict of interest is this one, BD APM, X Edwards. So I will start by SView2. SView2, I don't talk about SView2 right now, but SView2, which is a physiological, important physiological parameter. This is the oxygen saturation of the mixed venous blood. Mixed venous blood means venous blood in the pulmonary artery. So to obtain SVO2, we need a pulmonary artery catheter, by definition, if I would say. So now what are its determinants? So to well understand the determinants, we have to just go back to basic physiology for a few slides, and very simple slides. You know the Fick equation. The Fick equation applied to oxygen is this one. VO2 equals cardiac output times the difference in oxygen atom content between the arterial blood and the mixed venous blood times 10. So if we manipulate and simplify this Fick equation applied to oxygen, we can have the following equation, which is simpler and which uses only SVO2. This equation is SVO2 is or equals the SaO2, oxygen atom saturation, minus this ratio. And this ratio is VO2, oxygen consumption, divided by cardiac output times hemoglobin concentration times 13.4. This is derived from the Fick equation, but this is applied to SVO2. So it is simple. The main determinants of SVO2 is SaO2, arterial oxygen saturation, which is in general between 90% and 100%, and normal people above 92%. Another important determinant is oxygen consumption. Another one is cardiac output and hemoglobin concentration. So if you look at this equation, you have here VO2, and here the main factors, the main components of oxygen delivery. And according to this equation, SVO2 is considered an indicator of the VO2 to DO2 balance, like this. So a decrease in SVO2 can be due either to a decrease in SaO2, if cardiac output does not compensate for. In general, cardiac output compensates for this, and SVO2 is maintained constant. And this occurs very rarely. It occurs only in some patients with profound hypoxemia, less than 90% for SaO2. And in general, if cardiac output is able to compensate for this decrease, SVO2 does not change a lot. Another possibility to have a decrease in SVO2 is an increase in oxygen consumption. But again, if cardiac output does not compensate for this increase in VO2. And this can happen nevertheless in case, for example, of very sustained exercise. You have an increase in oxygen demand, an increase in oxygen consumption, which follows the increase in oxygen demand, and cardiac output also increase during exercise, as you know, but sometimes not enough to compensate for the increase in oxygen consumption, and therefore you can see a decrease in SVO2. But for moderate exercise, in general, SVO2 is relatively stable. This can happen for exercise, but this also can happen for any stress or even fever, shivering, which are responsible for increasing oxygen consumption, and also the use of thermogenic agents. For example, if you use dobutamine at high doses, dobutamine also increases the metabolism in the cells due to the beta-2 effects, adrenaline also, and therefore this can increase oxygen consumption, and if cardiac output does not compensate for, you could have a decrease in SVO2. And also, SVO2 can decrease simply because of a decrease in hemoglobin concentration. And again, if cardiac output does not compensate for this decrease in hemoglobin concentration. In the majority of cases, you should have an increase in cardiac output to compensate for the decrease in hemoglobin concentration, essentially in chronic conditions. But if you have a hemorrhage, acute condition of decrease in hemoglobin concentration, you should also have a decrease in cardiac output due to hypovolemia, and therefore SVO2 can be profoundly decreased. Okay, now the main determinant of SVO2 is simply cardiac output. And you can understand this because you know that if cardiac output decreases, the other components, I mean SCO2, VO2, hemoglobin, cannot compensate for this decrease, cannot quickly compensate for this decrease. And therefore, you could have a decrease in SVO2, an important decrease in SVO2. If I go back to basic physiology, and sorry for going back to basic physiology, because this is important to understand the meaning of SVO2, I have this equation I already talked about. And in fact, for example, a constant SCO2 and a constant hemoglobin concentration, we should have isoplets VO2. I mean, different relationship between SVO2 and cardiac output, for example, for a decrease in oxygen consumption. The shape is a little bit different, and therefore, a given value of SVO2, this is very important. For example, 60% can be associated with different values of cardiac output, depending on this value of VO2. For example, in the present case, you can see that cardiac output here is higher than in case of decreased oxygen consumption. So this is important to know that the same SVO2 value can be associated with different cardiac output values depending on oxygen consumption. So SVO2 is not the same as cardiac output. It depends on VO2 for this, and also it depends on SCO2 and hemoglobin concentration. Now, I have a constant VU2 and I have this kind of relationship. And if cardiac output decreases, for constant SCO2, constant hemoglobin concentration, and constant VU2, I told you before that these parameters cannot change very quickly, of course. SCO2 anyway is almost 100%. Hemoglobin concentrations makes time to increase. It takes 100 days for the red blood cells to be created. So hemoglobin concentration cannot change quickly if cardiac output changes. And the same for VU2. Therefore, in this case, you have a decrease in cardiac output, which is associated with a very, very marked, I would say, decrease in SVU2. But if you have a high cardiac output, this can happen in some patients. The same decrease in SVU2 does not change a lot or non-significantly SVU2. So again, you have to be very careful when you interpret SVU2, either the baseline value or its changes. It cannot always reflect the same change in cardiac output. It depends on the baseline value of cardiac output. And the same for the increase in cardiac output. If you have a hypovolemic shock or cardiogenic shock with a low cardiac output at baseline, and you give a treatment, either fluids or inotropic agents, you could have an increase in cardiac output. This is the expected goal of this treatment. And this can be reflected by a large increase in SVU2. So if you follow only SVU2, you can say, oh, well, my metabolic conditions improved a lot, and probably because of the increase in cardiac output. You can be happy for that. But if you start from already high cardiac output and you increase cardiac output, you have no change in SVU2, which is already high. And you cannot, if you follow only the changes in SVU2 because you have no cardiac output monitor, you cannot say, okay, my SVU2 did not change, so probably cardiac output did not change. No, cardiac output could have changed a lot, but you have on this flat part of this relationship. In addition, if you think about this condition of high cardiac output, you see that SVU2 does not change a lot. So maybe when you have a high SVU2, probably because of oxygen extraction alteration, maybe if you increase cardiac output, it will not change a lot the balance between oxygen consumption and oxygen delivery. So maybe it's not worthy to increase cardiac output when SVU2 is already high, because a high SVU2 means that SVU2 is close to SaO2, meaning chance, the presence of chance. And if you have chance, if you increase arteriovenous chanting, it means that if you increase cardiac output, this will increase the flow in the chance and not necessarily increase the flow around the tissues. So probably when you have a high SVU2, it is not worthy to increase cardiac output. So if I go back now to clinical conditions, I would say, according to this equation, in shock states, a low SVU2 suggests insufficient oxygen delivery with regards to oxygen needs. And therefore, this might incite clinicians to increase oxygen delivery. So this is a very practical message. If you have a low SVO2, you can say, okay, and the patient will shock. Okay, I know that I have to do something. I have to increase cardiac output or increase hemoglobin concentration. It depends. Not increasing SaO2 because it is already very high and you have no benefit to increase SaO2, but you could either increase cardiac output or increase hemoglobin concentration in order to increase oxygen delivery. So it is a very useful information. Another point, you know the relationship between VO2 and DO2. We know from physiology that DO2 can decrease from this part, high DO2 to low DO2, without any change in oxygen consumption. And this is the VO2-DO2 independence, because there are some mechanisms which help to extract oxygen from the tissues. And even if you decrease the oxygen delivery, still VO2 is okay and in adequacy with oxygen needs. But below a certain level, a critical level of oxygen delivery, all the mechanisms that increase oxygen extraction are at the maximum, and they cannot increase further. It's impossible. And therefore, if you have still a decrease in oxygen delivery like this, below this critical level, VO2 will decrease as well. And this is a VO2 dependence phase. In this phase, as you know, lactate is increased. In this phase, lactate could be normal. Okay, this is just to remind you the basic physiology. Everyone knows this. Every clinician in intensive care knows this. Okay, now what is the relationship between SVO2 and cardiac output? In fact, if you increase cardiac output while you are in this condition of VO2 dependence, VO2-DO2 dependence, meaning patient in shock, you increase cardiac output because cardiac output is low, SVO2 was low, and you say, okay, I know that we need to increase oxygen delivery. The main way to increase oxygen delivery is to increase cardiac output. But you also increase oxygen consumption because you can improve shock and increasing oxygen consumption if you look at this slope. And therefore, SVO2 will not change a lot because you increase oxygen consumption and you increase cardiac output at the same time. So it means that you could have no change or little change in SVO2. After this critical level of oxygen delivery, you have this increase, this relationship I already showed you before between SVO2 and cardiac output. Now VO2 is constant, is unchanged, and therefore you have this relationship we already described before. So what does it mean? It means that if you are resuscitating a patient with low SVO2, for example, 50%, and you give fluids, you give whatever you want. It depends on the mechanism of shock. If it is hypovolemic shock, okay, you can give fluids. But if you have no cardiac output monitor, You just follow your resuscitation with SVU2. And you see, oh, there is no change in SVU2. Maybe I used the wrong treatment. No. The absence of large increase in SVU2 during resuscitation is not an indicator of inappropriate resuscitation. It is totally normal. So if you have only SVU2, 50%, you give, for example, 2 liters of fluids because you think that this shock is due to profound hypovolemia, you give 2 liters and nothing happened. SVU2 remains low, maybe changing from 50% to 52%. Don't be discouraged. Don't be discouraged. Continue. It is normal until this critical level of oxygen delivery is reached. After this point, you will see a huge increase in SVU2, meaning that you were in the good direction. I hope that this is well understood because this is fundamental. And many intensivists totally ignore this. Okay, we know also, and we saw this before, that SVU2 can be normal or even high in shock states when the decrease in oxygen consumption is due to impairment of oxygen extraction and not due to a decrease in cardiac output or a decrease in the hemoglobin concentration. And therefore, you can have a patient with shock, sometimes very severe shock, but if you measure SVU2, can be normal value or even high values. For example, can be 75, 80%, or even 90%. It does not mean that everything is good. The patient can be in shock, but it means that there are severely impaired oxygen extraction capacities. So a normal or high SVU2 does not exclude tissue hypoxia. This is very important. Hypoxia is not defined by SVU2. SVU2 can help to understand the mechanisms responsible for hypoxia, but it does not define hypoxia. Hypoxia is better defined by lactate, for example, or maybe calibration time. And to emphasize on the importance of high SVU2 or SVU2, here SVU2, this paper showed that the mortality can be far higher with high SVU2 compared with SVU2 less than 80%. Because if you have profoundly altered oxygen extraction capacities, probably it means that you have a very severe shock, probably septic shock, distributive shock, and the mortality is higher because you have nothing to do in terms of hemodynamics. You cannot increase cardiac output. It is totally ineffective, and you have just to wait for the benefits of anti-infectious treatment, for example. So, because we use less PA catheters now, at least in my country and maybe in your country, in Sri Lanka, we use more central venous catheters. And the question could be, does SVU2, central venous oxygen saturation, correlate with SVU2, again, which is a mixed venous blood oxygen saturation? So there are some studies comparing both, and globally, I will be very fast for this topic. Globally, yes, it's not so bad. The percentage error here is only 11% between SVU2 and SCVU2 in this paper, and the trends are acceptable. The correlation was 0.75. So it is admitted by experts that we can use SCVU2 if we have no PA catheter in place. And in this expert panel paper published 10 years ago now, from the ESICM, we already said SCVU2 is used as a surrogate of mixed venous blood oxygen saturation, which finally reflects in real time balance between oxygen consumption and oxygen delivery. And we said also that we can use SCVO2. And a question could be, can SCVU2 be an endpoint of resuscitation? Maybe you remember, maybe not, this important paper published 25 years ago in the New England Journal of Medicine by Rivers and co-workers. They compared two strategies in patients with septic shock. One strategy was based on SCVU2. The endpoint was SCVU2 above 70%, and the other strategy was based on CVP, MAP, and urine output, and also in the early goal diuretic therapy group, also CVP, MAP, and urine output were used, but the ultimate endpoint was to obtain a SCVU2 above 70%. And there was in the single center study performed in the early phase of septic shock or stay in the hospital, in a majority of cases in the emergency department. In the first 6 hours, the authors, Rivers and co-workers, observed a very impressive decrease in hospital mortality, 28-day mortality and 60-day mortality. Very impressive. And this is why, after this paper, SCVU2 using a central venous catheter has become very popular. And this was recommended for years and years by the Surviving Sepsis Campaign. It was said that you should use SCVU2 or mixed venous oxygen saturation if you have a PA catheter, and the targets were 70% for central or 65% for mixed venous oxygen saturation. This was like a reference, a gold standard, until 2022, the publication of the Surviving Sepsis Campaign 2012, 2012, if you want. I don't know how to say. But 4 years later, in fact, the publication comes from 2017, but 4 years later, a new version of the Surviving Sepsis Campaign was published. And if you look at this version, and also the last one from 2021, there is no mention to SCVU2 anywhere in the multiple recommendations. No mention. Why? Probably because the publication of 3 randomized controlled trials in the meantime, between 2012 and 2016, which were the ARISE, PROMISE, and PROCESS trials. The REVERSE trial was a single center randomized controlled trial. These ones were multi-center randomized controlled trials. And they compared usual care to early goal diuretic therapy with SCVU2 as an endpoint. And they took the same target, 70%. As you can see, there is no improved survival with early gold dilator therapy. And these studies totally destroyed the use of SCVU2, since now it is not recommended by the SSC guidelines. But there is always a but in presentation. But we have to be very cautious because patients were far less sick than in the reverse study. And their mean SCVU2 was already above the target, above 70% at the inclusion time, because they received a lot of fluids before inclusion, which was not the case in the randomized controlled trial by reverse. And therefore, by design, these studies could not show any benefit of targeting SCVU2 above the target, above 70%, because it was already above 70% in both groups. So it was not possible to show any difference. And these studies cannot tell anything about the utility of targeting or not SCVU2 when SCVU2 is lower than 70%. In other words, if SCVU2 is 50%, probably, maybe, it is beneficial to use SCVU2 and to use a target of 70%. And this situation is not uncommon. In this study by Boulin and co-workers in France, they included 365 patients with septic shock, and the prevalence of initial SCVU2 less than 70% was 27%. And they obtained this value when they performed, of course, measurements through a central venous catheter. So probably it was lower than 70% in more cases at the initial phase before the central venous catheter was placed. Nevertheless, 27% is not negligible. You cannot ignore these patients. In addition, in their paper, they show that after 6 hours of resuscitation, and in cases of hyperlactatemia, there was a lower survival when the SCVU2 at H6 was lower than 70%. In other words, if you combine lactate and SCVU2, you have a better estimation of outcome. This is why, in spite of the publication of the SSC guideline and so on, in the ESICM, European Society of Intensive Medicine, with Jean-Louis Vincent, Mervyn Singer, Daniel De Backer, big names, we still recommend optimizing oxygen delivery based on clinical assessment complemented by careful hemodynamic assessment, including measurement of mixed or central venous oxygen saturation. And more recently, it was published some weeks ago in Intensive Medicine, the ESICM, European Society of Intensive Medicine, with Xavier Monet, Jan Bakker, Marcel Cicconi, etc., many people. We said in patients with a central venous catheter already in place, serial measurements of central venous oxygen saturation should be performed. It was a very strong recommendation, but it was an ungraded good practice statement, but a very strong agreement among experts. So still in 2026, because this paper was published in December, in 2026, last December, it is for us, for European people, it is still recommended to use SCVU2 in patients with shock, of course. And we also said that in patients with a central venous catheter and an arterial catheter already in place, serial measurements of the veno-arterial difference in PCU2 should be performed. And again, it was an ungraded good practice statement, but a strong agreement between experts. So it is still a stronger recommendation of this group of experts coming from the ESICM. So, what is PCO2 gap? Because this is PCO2 gap. We call it PCO2 gap. So what is PCO2 gap? What is the physiological meaning of PCO2 gap? Again, you know me now, you know that I like to go back to basic physiology, but very simple physiology. And now I will talk about the Fick equation applied to CO2. Before I told about the Fick equation applied to oxygen. Now to CO2. So, according to this Fick equation, the difference in CO2 content between the mixed venous blood and the arterial blood equals the CO2 divided by cardiac output. And again, the relationship is not linear, but hyperbolic, like this. So we can say that PC2 gap, but PC2 gap, not PC2 gap, but CO2 gap for the content equals this. The issue is that it is very complicated at the bedside to obtain CO2 content. For example, this is a formula which is proposed to blood CO2 content for the arterial blood or for the mixed venous blood. Look at this complex and too complicated equation, so it is not feasible at the bedside. This is why it was proposed to replace CO2 content gap by PC2 gap, delta PCO2, which could be equals to K, which is a factor times the change in CO2 gap, in CO2 content gap, sorry. So if we simplify this equation, we could have the following equation, which is a simplified Fick equation applied to CO2, PCO2, which is PCO2 gap equals K, this factor, times the CO2 divided by cardiac output. PCO2 gap depends on K, which is a factor defining the relationship between PCO2 and CO2 content. Also, global CO2 production. For example, if you make exercise, you have an increase in the oxygen consumption, and therefore you should have an increase in the global CO2 production. It's normal. So your PCO2 gap should increase, but cardiac output should compensate a little, and therefore PCO2 gap increases, but not so much, except if cardiac output cannot compensate for this increase in VCO2. But VCO2 is an important parameter to consider. But of course, the most important parameter to consider is cardiac output. And again, this is a relationship between CO2 content gap, you can put PCO2 gap instead, and cardiac output. In fact, when you have a high cardiac output, you have small changes in CO2 gap. When you have a low cardiac output, you have large changes in CO2 gap, coming from this hyperbolic relationship. So why? Because physiologically, in case of a low cardiac output, you have what we call a CO2 stagnation phenomenon that results from a low clearance of the CO2 produced at the periphery. If you have a low cardiac output, there is an accumulation of CO2 at the periphery because the venous blood flow is low, and the efferent venous blood flow is low because cardiac output is low. You know that efferent venous blood flow equals cardiac output, So because there is a low efferent venous blood flow, a low clearance of CO2, and there is stagnation of CO2 in the periphery, and a big difference between the PaCO2 and PvCO2. So we know that higher than normal PCO2 gap is not a marker of tissue hypoxia. It is not a marker of tissue hypoxia, but it is an excellent marker of insufficient global blood flow, insufficient cardiac output with regards to the metabolic needs, of course. And this is what we confirm in this study we perform in animals with Benoit Vallée, but I will skip this experimental study because of lack of time. But in this study, we demonstrated that this is a result. PC2 gap increases in case of tissue hypoxia with low blood flow, but did not change in case of tissue hypoxia with preserved blood flow. In other words, if you have a high cardiac output and shock, for example, some septic shock, you could have a normal PC2 gap. But if you have a high PC2 gap, it means that cardiac output is not enough. So the take-home message we should keep in mind for PC2 gap is that PC2 gap depends much on cardiac output, especially in the lowest range of cardiac output values, is not a marker of tissue hypoxia. When it is normal, I mean less than 6 liters of mercury, this suggests that elevation of cardiac output cannot be a priority in the therapeutic strategy. And a high PC2 gap, more than 6, suggests that elevation of cardiac output may be a good therapeutic option. And again, it is very convenient to have this value because sometimes you have a shock plus high SVO2 or SVO2 between 70% and 80%. You don't know if you have to increase cardiac output because you know that SVO2 is not reliable in this kind of situations. And you look at PC2 gap. If it is less than 6, your priority is not to increase cardiac output. But if it is higher than 6, this becomes your priority to increase cardiac output. It's very convenient. What about SCVO2? About central venous minus arterial PCO2. Is it acceptable? Yes, it is acceptable as a reflection of mixed venous arterial PCO2. So we can use the central vein if you have no PA catheters. Is it a marker of outcome? Yes, it is. This is a meta-analysis showing that when you have a high value versus low value, the mortality is higher in case of high value. And also, the change in PC2 gap during resuscitation are very interesting to look at. In this paper, when you have a low PC2 gap in case of septic shock, low PC gap at H0 remaining low at H6, the survival rate is high. The same if it is high at H0, but it becomes low at H6. But the worst situations are low PC2 gap at H0 becoming high at H6, meaning your resuscitation is totally wrong, or high PC2 gap at H0 remaining high at H6, meaning that your resuscitation is totally ineffective. If you want to know more about this topic, just know that there is a recent paper published in Annals of Intensive Care, published in 2025, about the use of CO2-derived variables. Now, and to finish my presentation, how should we use SCVO2 and PC2 gap properly together? I start from a patient with septic shock, defined by whatever you want, hypotension, mottling, increased capillary time, or hyperlactatemia. And I recommend, and I'm not the only one to recommend, we recommend, at least in the environment of the ESICM, to measure SCVO2. If you already have a central venous line in place, but it is many times the case in patients with septic shock. You measure SCVO2, and you have 3 possibilities: low SCVO2, high in SCV2 more than 80% and intermediate values between 70 and 80%. In case of low SCVU2, inadequate oxygen delivery is likely. An attempt to increase oxygen delivery is totally logical. In the majority of cases, by increasing cardiac output if hemoglobin is not too low. This is what we said in this paper. A low SCVU2 may indicate insufficient global oxygen delivery in case of shock and incite one to increase oxygen delivery. Now, the opposite situation. You have high SCVU2 above 80%. It means, in case of shock, that there is a severe alteration of oxygen extraction. An attempt to increase oxygen delivery is illogical for the reason I told you before, because if you have alteration of oxygen extraction, even if you increase blood flow, the flow will increase in the arteriovenous shuntings, but not to the tissues. Again, this study I already showed. Now, what to do in case of SCVU2 between 70% and 80%? Should a further increase in oxygen delivery be discouraged? Sometimes yes, sometimes no, you don't know. And how to identify patients who could benefit from an increase in oxygen delivery when SCVU2 is above 70%, between 70% and 80%. And this is a place of PC2 gap. It is the optimal place of PC2 gap. Two possibilities. Either PC2 gap is more than 6, and you know that probably there is something to do with the increasing cardiac output, because in general it means that cardiac output is inadequate to metabolic conditions. And this is what we said in this other paper with other experts, Michael Pinsky, you probably know, Jean-Louis Vincent, Daniel Baker, and others. We said that high PC2 gap identifies patients for whom an increase in cardiac output may be beneficial in sustaining organ perfusion despite SCVU2 above 70%. This is the ideal situation. But we also say that if it is lower than 6, it is unlikely that increasing cardiac output will reverse organ hypoperfusion, and this should be discouraged in this case. It's not a priority. And this is, again, my final slide, or almost final slide. In patients with central venous catheter, we should measure SCVU2. That is a strong recommendation from the ESICM. And in patients with a central venous catheter and arterial catheter, patients with shock, we should measure PC2 gap. Again, a strong recommendation. I would like to thank you very much for your attention. Thank you very much.
Thank you very much, Dr. Chebel, for that wonderful, informative lecture. So I think we have some of the questions in the chat box. First question would be, do you routinely do central venous oxygen saturation in optimizing hemodynamics, or what triggers will make you measure?
I hope that I answered this question. Maybe I was not clear enough. Of course.
Sorry. Yeah. So the question was, do you routinely do central venous oxygen saturation in optimized hemodynamics, or what triggers will make you measure it?
No, my presentation, from my presentation, it is clear for me that we need to use central venous oxygen saturation in patients with shock. If you already have a catheter, central venous catheter in place, and this is a recommendation of the ESICM recently published in Intensive Medicine in last December. So yes, routinely, if you have a central venous catheter, it is a pity in patients with shock. Of course, I talk about patients with shock. In patients with shock, it's a pity not to use this central venous catheter just to blood, to sample blood and venous blood, and to have an idea of the SCVO2. It is very quick. You have nothing to do, just blood sampling. That's it. I don't talk about fiber optic probe, which is very costly, very expensive, and which are not appropriate. I talk about blood sampling, which is doable in every place, every setting. And of course, I recommend to do this, and I do this routinely. Nevertheless, in patients with shock, it could be normal or high. And if it is normal, you should have P2 gap measurements in addition. If it is high, it means that SCVO2, if SCVO2 is high, it means that you have oxygen extraction alteration, and therefore it is also an indication that your patient is probably septic and probably very, very severely septic, and in this case, it's not recommended to increase cardiac output.
Right.
What is the other question? And the target is 70%.
Okay, right. The next question is, sometimes it's confusing how to make use of central venous oxygen saturation at bedside when the patient is on high FiO2. How do you deal with this?
No, it's not an issue. It's not an issue because it does not depend on FiO2. It depends on SaO2. SaO2. And in general, if you use high FiO2, is to normalize SaO2 above 92%, 93%. So if you have a normal SaO2 or a normalized SaO2 by high FiO2, the meaning is exactly, the meaning interpretation exactly the same as for SCVO2. It's not an issue. It is not an issue. Could be an issue if you have a very low SaO2. If you have a very low SaO2, for example, I don't know, 70%, but 70% is very exceptional. The patient is almost dead. But if you have a very low SCVO2, by definition, you have a low SaO2 because of low SVO2. In general, in ICU patients, and believe me, and you are intensivist, you know this very well, it is exceptional to have SaO2 lower than 90%. And therefore, this is not an issue for the interpretation of SVO2.
Okay, right. So the next question is, if you can echo the patient and you have got a decent cardiac output monitoring device, how useful is the PCO2 gap and central venous oxygen saturation in day-to-day practice?
Simple answer. No, simple answer. SVO2 is a marker of the adequacy of cardiac output to the metabolic conditions. Or disons, no, the adequacy of oxygen delivery to metabolic conditions. P2 gap is a marker of the adequacy of cardiac output to the metabolic conditions. Adequacy, marker of adequacy, both. So you could have values of cardiac output by using echo or by using cardiac output monitor, but if you have no idea of SVO2, you don't know if the value you look at, the value you displayed on the screen is adequate or not adequate. You could have 3 liters for cardiac index. Sometimes it is adequate, you have nothing to do in terms of increasing cardiac output. Sometimes it's not adequate. And SVO2 or P2 gap can tell you this. If you have no measurements of SCVO2 and P2 gap, you cannot know if it is adequate or not adequate. You cannot rely on any value of cardiac output to interpret any value of cardiac output, you need to know if it is adequate or not.
Yes. Next question is, do you use femoral venous sample for CO2 gap or central venous saturation?
No, I don't recommend to do this because we need to have something which is very close to the mixed venous blood. I don't know if I was clear enough, but physiologically, the meaning of SVU2 or the meaning of PCO2 gap is when you are very close to the mixed venous blood. So we consider that the central venous blood is not too far from the mixed venous blood. But if we are too far because we take the value of femoral venous blood and not central venous blood, we cannot interpret reliably, I would say, the measurements of markers of the adequacy of either oxygen delivery to metabolic conditions if we take SVO2 or PIS2 gap if we as a marker of the adequacy of cardiac output. So the more far you are from the mixed venous blood, the less reliable are values of SCV2 and PIS2 gap.
The next one is, what is the benefit of CO2 gap over echocardiography in deciding on benefit of cardiac output increment during resuscitation?
No. Again, sorry to repeat, but echocardiography is an important thing to do at the bedside in patients with shock, because you can have values of cardiac output, but you also can have ideas about the mechanism of cardiac dysfunction or mechanism of shock. So it is very important. But again, echocardiography cannot tell you about the adequacy of cardiac output to the metabolic conditions. SVO2 can do this when it is low, and PIS2 gap can do this when SVO2 is not low. That's it.
Yeah, thank you. And the next one is, does the value of PCO2 gap is correlate with the severity of shock? Can we use the trends of PCO2 gap in resuscitation?
Yeah. I don't see where is the question.
In the chat, actually.
Yeah. But I don't see
the last one. Yeah.
Yeah. So, does the value of PIS2 gap is correlated? A strong correlation? No strong correlation. Nevertheless, if you have a PIS2 gap of 7, which is higher than 6 by definition, probably the situation is less severe than PIS2 gap of 12, and this can happen. But again, you could have a normal PIS2 gap and a very severe shock. Again, normal PIS2 gap and very severe shock when you have alteration of oxygen extraction and how to say, adequate cardiac output. But the problem is not cardiac output. It's not to increase cardiac output. The problem is to wait for some benefits from anti-infectious treatment. For example, antibiotics appropriateness. For example, sometimes evacuation of some abscesses, source control, if you want. So sometimes you have the worst situation is to have shock plus high SVO2 plus normal PIS2 gap. Because in this case, 3 conditions, you have nothing to do with hemodynamic treatment, only anti-infectious treatment. And this is a worse situation because you have no ways to improve hemodynamics. So the problem is not hemodynamics. The problem is control of infection. So this is why there is no correlation between severity of shock and PIS2 gap. Of course, if you have a very high PIS2 gap, it is probably more severe than moderately high PIS2 gap, but you could have totally normal PIS2 gap and very severe shock. This is a problem. This is a problem. So again, PIS2 gap can help you to think if cardiac output is adequate or not. If you have to do something with cardiac output, if it is low, you have nothing to do with cardiac output, whatever the severity of shock. If it is high, it's not so bad because you can maybe improve the patient by increasing cardiac output. I hope that is well understood the questions. I'm not sure, but I hope that people understand around or not around because we have no table, we have no people who are attending this webinar understood what I said. I know that it is a little bit complex, and this is why you wanted to have more about this topic, because it is not correlated. There is no correlation. It is just to understand what is physiology and how to apply physiology. Again, the adequacy either of oxygen delivery for SVO2 and essentially what it is low. When it is low, it is very useful. When it is not low, it is a place of PIS2 gap. And if PIS2 gap is normal and SVO2 is normal or high and patient still in shock, this is not a problem of hemodynamic treatment, it's a problem of anti-infectious treatment.
I think
we are at the end of this webinar.
Yeah, I think we have answered all the questions. And Dr. Anushka, I think you can unmute.
Yes.
No,
yeah.
Yeah.
Thank you for your comments.
Yes. So, Professor Teboul, that was an excellent talk. I know you had to explain some points again and again, but it was well said, very well done. So, thank you very much. The audience, for the final time, do you have any questions to ask? You can unmute yourselves and ask before he leaves, actually. We'll just give them 30 seconds. Let's see.
Anushka, do you think you would let me give me 2 minutes to ask a question?
Yeah, sure. Yeah.
Prof. Teboul, thank you very much for the super lecture and the explanations. I'm Bhagya Gunatilaka. Quick question. Do you think the carbon dioxide, centrovenous carbon dioxide or arterial carbon dioxide, the effect of shock on dead space or pulmonary perfusion could have an impact on this arterial and venous carbon dioxide difference?
Thank you. This is an excellent question. Normally, no. PIS2 gap relates to venous blood flow and the adequacy of venous blood flow to clear the CO2 which is produced at the periphery. And PaCO2 relates to the lung function, If your lung function is altered, or if you have hypoventilation, whatever, PaCO2 can increase or decrease, etc. PaCO2. So PaCO2 for the lungs and PC2 gap for the hemodynamics. This is my answer. Because we use PCO2 gap just to, how to say, to adjust for PaCO2. And PaCO2 depends on the lung function. So if you use only PvCO2, you can be confused because it can be high due to some hypoventilation, alveolar hypoventilation. And this is why we take the difference between PV and PA to adjust for the lung function. And now PC2 gap becomes a wonderful marker of what it happens in terms of hemodynamics and nothing to do with ventilation. This is the beauty of PC2 gap. I hope that I am clear enough.
I hope that cleared your query, sir. Any other questions? Okay, then I don't want to take your time anymore, Professor. So thank you very much again for taking your time and enlightening us on this all about carbon dioxide and oxygenation. So thank you very much for that very enlightening talk. So hope to see you again. I really hope our colleagues and our trainees, they got the opportunity to talk, to hear you talk, and I hope that we get another chance to hear you talk in the future as well. So good luck with all your endeavors, and have a good evening, and everybody else, good night. Thank you very much for joining. So we will
Thank you very much, Anushka, and thank you for all the attendees. Thank you for listening to me, and I hope that it was clear enough. But again, there are some papers like the paper I showed before, recently published, and you can have a comprehensive reading of the gap, which is a little bit difficult, but this paper published some weeks ago or months ago can help you for sure. Thank you.
Okay, see you.
Bye-bye.
Good night.
Good night.